All right, I'm going to resume recording. Sorry that the link came out a little bit late, but if you didn't preview, that's totally fine. I think we will go through in a stepwise fashion in terms of, you know, just having people at least describe what they see, and we can talk about differential diagnoses. I just put a few articles, a few review articles on epithelioid tumors in the link that was sent yesterday, and, you know, in the little paper clip. And I'm going to share. All right, you guys can see that?
Yeah.
Cool. All right, do anybody have any questions or comments before we start? All right, cool. So if you all liked the control screen, drive it yourself and describe what you see, we could do that. If anybody wants to try it, let me know. This is the first case. It's obviously a resection. Any brave volunteers?
Link it up, give me a minute.
Nobody likes the remote control driving.
I struggled with it last time, if I'm honest.
Yeah, I think it's really hard if you have a touchpad, easier if you have a mouse. Anyway, all right, so here's a neoplasm that, well, if at least if you guys don't drive it, I'll drive it, but who wants to describe this thing?
I'll go first if no one else wants to. We have a very, very highly cellular lesion that's apparent, that looks like it's, I'm not sure if it's invading fat. There's like, there's some fatty vacuoles in between. So I think we're actually, it looks like it's invasive of the fat. I'm not sure what the anatomic site is. It doesn't look like clearly to be a subcutaneous lesion. So I can't start to try to put this in DFSP territory. Going in higher power, the overall architecture is kind of nondescript. If you go to very high power, it looks like it has like a focally kind of whorling or storyform architecture. As far as salient cytologic features, some of the cells kind of seem vacuolated. Some of them actually take on kind of a, almost like a signet ring appearance in a few locations. Not so much here, but maybe more to the left. And there is very, very fine separating a collagen. Sort of nondescript so far. It's monophasic. I see one cell population. As far as lineage goes, I'm not sure if vacuolization is the right way to describe it, but do you see what I mean over on the kind of like on the left-hand side where there's a little more clearing?
Yeah, I would probably say at least just kind of cytoplasmic clearing.
Let me think. Could this be like a monophasic synovial sarcoma?
Okay.
What would I have on the differential? Trying to think what else I would have in the differential for that. SFT.
Okay.
Was my first thought, but
it does have this, like you're saying, these intervening kind of eosinophilic bands, right? So you think about tumors that have that stromal deposition, and SFT is certainly one of them. What other tumors in soft tissue families, or even soft tissue and or bone, might present with this stromal pattern with relatively monotypic but highly cellular, not too many mitoses, right? Not so much necrosis, although there was some stromal kind of degenerative change. All right, so if you're thinking SFT, what would you want to stain it for? And I'll tell you what it would be.
Well, C34 and STAT6, and NAB2 if we have it, which I don't think we do.
No, so STAT6 being the most specific for SFT, in this case would be negative.
Okay.
And synovial sarc, what would you stain it for?
First of all, a lot of them can be keratin positive.
Mm-hmm.
I'm trying to remember, there's a more specific stain though that I'm blanking on, and that relates to the translocation, doesn't it?
Mm-hmm.
The
You meant for
TLE1.
EMA and TLE.
Exactly. So you all have said it in the comments. So EMA and TLE1. So I will tell you that this thing is going to be EMA positive, and TLE, it's not a synovial sarc. I'll tell you that right away. But TLE we've found to be less specific for synovial sarc, and it stains a lot of sarcomatoid carcinomas. It stains other sarcomas somewhat undifferentially, indiscriminatorily. So I would just be cautious in your interpretation of TLE1. But this does stain with EMA. So a lot of these soft tissue tumors that we're going to be seeing today that are sort of plump, right, rounded epithelioid morphology, the pitfall in a lot of them is that they stain for EMAs and or keratins. Okay, so just remember that if a soft tissue sarcoma is going to stain for an EMA or a keratin, it's going to tend to be of the epithelioid morphology. Maybe something about its differentiation to produce cytokeratins makes it plumper. I don't know, but it kind of fits. Epithelioid morphology tends to express EMA or keratin. So this does express EMA, and it does have these collagenous bands, but it's not synovial and it's not SFT.
Just curious, I'm seeing a lot of red cells kind of extravasated here, or maybe not extravasated. Does this stain with any vascular markers?
No.
Okay, got no idea then.
Anybody else before I divulge? This is one of these tumors that, while you think I'm going to talk, this is one of these tumors that could also occur in bone. And so if you were to have placed this thing in bone, what's one pitfall in interpretation of this material?
Trying to call this osteoid?
Trying to call this osteoid, exactly. So, you know, collagen versus osteoid isn't always easy to determine. You know, Krauss uses some polarization and some occasional stains. There's these theories out there that SAT-B2 as an immunomarker is more specific for osteoid, osteoblastic differentiation in the cells producing it, but that's also been a little wishy-washy. So there's really no great differentiator between osteoid and not osteoid except morphology. And so this is very linear. It's very linear rather than kind of globular. And at least in this case, it's in the soft tissue, so that helps a little bit because soft tissue osteosarcomas are rare. But these can happen in the bone, and this collagen is a pitfall for osteosarc. So before I divulge the diagnosis, anybody want to shout anything else out? All right, so this is sclerosing epithelioid fibrosarcoma. So we talked last time about low-grade fibromyxoid sarcoma, right? And we mentioned, hey, what about sclerosing epithelioid fibrosarc? Isn't that kind of a high-grade transformation of low-grade fibromyxoid? Yes, and here it is, okay? So this is characterized by it almost kind of looks like lobular carcinoma with these files of cells in this fibroblast collagenous stroma. And so the cells tend to be pretty monotonous, tend to be relatively bland, like not very pleomorphic, not very mitotically active compared to our other high-grade sarcomas, right? But they stain for EMA, and just like low-grade fibromyxoid, they stain for MUC4. If they arise from a low-grade fibromyxoid, they retain the same genetics, which are FUS-CREB. If they arise de novo, they tend to have EWSR-CREB, but CREB is the unifying factor in all of them, okay? So this is a pretty classic example of sclerosing epithelioid fibrosarc. So I would, you know, take a look at this, burn this into your brain, remember this lacy collagen in the background, and the lining up of cells, that's SCF, all right? And usually, you know, trunks, extremities, but bone, bone, bone. And so this is a pitfall in bone for osteosarcoma. All right, questions? All right, the next one I'll drive, but who that's not Tim is going to describe. I'll tell you already that we are in some squamous lined site that I do not see skin adnexae, so I assume we are in a mucosal site. Silence.
I'll try. I think
Thank
it's
you.
so yeah, we're a mucosal and it looks like we have some sort of like nodular formation, like pale, and it looks like it's extruding out of the mucosal squamous lining too. Up here, I guess it kind of is protruding out. Maybe we can go zoom in into one of the more nodular areas just to get a closer look. Okay, I think I have a better idea of what's going on here, or maybe not, we'll see. So, I mean, like these are, you know, eosinophilic cells that are nested. From what I can tell, they all kind of look like they're the same cells, and these cells have like sort of wispy wispy cytoplasm, nuclear, relatively, I think, low grade. I don't see any mitotic figures right now. Maybe there's one. Oh, there's maybe.
What strikes you about the nuclei?
From nucleoli,
Mm-hmm.
and cleaved a little bit.
Yep.
I don't know. I feel like this has an alveolar appearance to me. So I'm thinking of like a alveolar rhabdo, but like I don't. And I guess like the cytoplasm is quite pink too.
Mm-hmm. Mm-hmm. Yeah, no, great. So I think the salient features are this growth pattern, this very, very nested, packeted growth pattern that, you know, reminds you of like a paraganglioma, a clear cell renal cell carcinoma, pulmonary alveoli, right? So you said this word alveolar, which basically means nested, right? And separated by this delicate vascular stroma. And so let me launch the poll. Can you guys see that?
Yes.
Okay. Probably not everything that you would want to think of is on here. I basically put some of the diagnoses that we're talking about today. But, you know, to remind you, this is a nested tumor that has wispy, or one might even say focally, maybe granular cytoplasm. The nuclei are large with prominent nucleoli. And so you do want to think about the epithelioid tumor differential, and you want to think about the, perhaps the nested tumor differential. This is actually one that, you know, because of where I am and who I am, this is a tumor that not uncommonly arises in head and neck sites, of which we are. I believe we're in the tongue. You can see the nice intersecting muscle bundles here. So this is arising in the tongue. Certainly, because we're in a soft tissue lecture, you know, it's going to be a soft tissue tumor, but you always want to think of your differential of things that could arise in mucosal sites. And we didn't see any overlying dysplasia. It's quite deep, and it has a very sort of nested, solid appearance. Very, very prominent nucleoli, very nested, very granular. So half people voted. Huh. How funny. All right, I'm going to stop the voting. Do I even have? All right. This was a trick. The diagnosis isn't on here. Okay. So does anybody have any other votes for what this is now that you know the diagnosis is not on your poll?
I wanted to call it a PCOMA.
Alveolar soft part sarcoma.
Yes, so I think alveolar soft part sarcoma and PCOMA are also excellent ones to put on the differential. This particularly is an alveolar soft part sarcoma. So I'm gonna discuss what you guys voted for in terms of sort of what the winner of the wrong cases was malignant extrarenal rhabdoid tumor, and I think that's also a very good thought. because a lot of these tumors have this morphology of abundant cytoplasm, right, with big nuclei, with prominent nucleoli. And that includes alveolar soft part, that includes rhabdoid tumor, that includes, what did you say, pecoma, right? But I think the thing that is particular about this is really that nested growth pattern. And so I'm gonna stop this now because that was bad of me to put something that there was no right answer for on there. So this is a tumor of more often younger people, as I said, in the head and neck, but it could also be in the deep soft tissues. This delicate vasculature separating the tumor into nests. Classically, for those who are taking boards, you may be given some kind of electron microscopic image or even a PAS type of appearance of these rhomboid intracytoplasmic crystals. Because of course you could see the rhomboid on the EM, you can't really see them on the light microscopy, but you can see that there are these filaments in the cells, and that appears makes this wispy kind of granular appearance to the cytoplasm. Specifically, TFE3 is going to be your diagnostic immunostain. So some of them have Desmond, some of them have S100, which can start to expand your differential diagnosis. But if you have this morphology, I would say TFE3 is going to be your most specific, reflective of the translocation. These can, as it is shown here, metastasize. So they're kind of considered a potentially high-grade sarcoma. What was I going to show you? I don't remember what I was going to show you now. So those of you who, start calling on people, I will. So if you voted anything else, good for you, because I was sneaky. All right, do you guys have questions or comments on alveolar soft part? Oh, I know what I was going to show you. I don't think we have good examples here, but sometimes the nests could be, here it is, so discohesive that they lose the solidness and you almost retain only like the peripheral rim attached to the vessels. So be mindful that sometimes alveolar soft part sarcoma can lose that central cells and be left only with the peripheral cells attached to the stroma. Okay. All right, next one. So whoever of you guys last time asked for core biopsies? Maybe it was Kyle. Maybe it was Luke. Who wants to volunteer to discuss this core biopsy?
I can discuss it, that's
okay.
Fine. So right off the bat, it's more eosinophilic, right? Oh, there's a little bit at the end of two of the three cores that is very blue, and I don't know if that's hitting the lymph node or not.
Could be.
Yeah, I kind of favor that more of a lymph node. All right, so it looks, at least from medium power here, coursing through it, you kind of have some kind of thick, what seems to be collagenous bands. When you dial down on these nuclei, or excuse me, the cells, you kind of appreciate that they have like little lumina, right? So, I mean, one thing that you can think of is maybe is this brass, like lobular, but I think you're going to tell me that the site is probably not of, you know, breast.
How about axillary lymph node?
Okay.
Actually, I think that's what this was.
Okay. But either way, you'd probably obviously want to make sure if it is a female that you definitely want to work that up into your differential. But the cells kind of have indistinct borders, and the nuclei are kind of, some of them are pushed off a little bit by the intracytoplasmic lumina. Overall, I don't appreciate a ton of mitoses. And I think this time you do have the actual diagnosis in the differential on the pole. So, but
all right, so pause there. Excellent. So when you're thinking about a in fact, this was a woman with an axillary mass and potentially lymph node involvement. And so you say, I want to rule out lobular breast cancer because it's kind of single file. There's kind of some signet ring cells. What stains do you think are going to help you?
I think like at least determine origin of the cells. So maybe like a GATA3 would help. And then if that is in fact positive, then you could kind of do more specific markers, like maybe like an ECAT here, and see if she had prior diagnosis, you know, whether you look for the positivity of ER, PR, and HER2 and see if it matches. If this is like a de novo or an unknown primary, then you would want to do those anyway, just for prognostication and diagnostic and therapeutic purposes.
Okay. So you want to do a GATA3, maybe some ER, PR if it turns out. Anybody else want any other immunostains?
I guess you could do like mammoglobin or something like that.
Okay.
CD31.
Okay, because you're thinking?
Oh, vascular, sure.
Hemangioendothelioma.
Okay.
Yeah.
All right, so, right. So this is another extraordinarily characteristic and classic morphology of epithelioid hemangioendothelioma. All right, so again, this kind of is in a single file pattern, embedded in some stroma, but the cells are extremely plump, right, extremely pale pink, and have these very clear vacuoles that might make you think about a signet ring cell, like in a carcinoma. Might make you think even about what? A lipoblast, right? They're kind of compressing the nucleus a little bit. And so if you are thinking about, oh, that's a good one that almost sort of starts to resemble a lipoblast. But I don't know any liposarcomas necessarily that are quite this plump, quite this linear, and stain for two important things, one of which was already mentioned, which were vascular markers like CD31, CD34, ERG, and the pitfall of all epithelioid sarcomas, keratin, right? So don't put a keratin on this and think, yep, this is breast cancer, okay? This is epithelioid hemangioendothelioma. If we are lucky, we may see endothelial cells within these. So these are not, oh, there's maybe one right there. So these are not filled with mucin. These are basically intracytoplasmic lumina, right? So in this case, the tumor cells are trying to form vessels, but it's within an individual cell, okay? So we may not get a great, perfect red blood cell in an intracytoplasmic lumina, but that is an incredible clue to the diagnosis. Does anybody remember what these cells are called? Here's a couple red cells, I think.
Blister cells.
Blister cells, okay? So as a reminder, I think I probably took these photos from exactly that case. So here's keratin in the epithelioid hemangioendothelioma. So remember, what does the term hemangioendothelioma imply?
Rising out of a vessel.
It has an endothelial morphology.
Okay, so it's of endothelial lineage, and specifically, what else does hemangioendothelioma imply?
Low malignant potential.
Right. So this is in the spectrum of vascular neoplasms. There's benign angiomas, there's malignant angiosarcomas, and there's intermediate or indeterminate malignant potential hemangioendotheliomas. So just remember that as your category, right? So these are not overtly aggressive, but they can occasionally metastasize. It's thought that they can arise in essentially any body site, visceral, soft tissue, bone, anything, anywhere. Sometimes they can be multifocal, and it's thought that maybe the multifocality are actually metastases from a single primary. The diagnostic translocation is this WWTR campta. So the thing that I want you to take home here is the linear morphology, the plumpness of the cells, the intracytoplasmic lumina, and the fact that this is not vasoformative. Okay, so epithelioid hemangioendotheliomas, other than the little blister cells, do not actually form vessels with multiple cells. Okay, so that's a key in differentiating it from other vascular lesions. And it's keratin positive, right, which is a pitfall for carcinomas. But carcinomas shouldn't really have 31, 34, or ERG to any significant extent, and these will be nicely, strongly positive, okay? Questions? Right, so GATA3, of course, would be negative, ERPR would be negative, E-cadherin should be negative. Okay. Who wants to describe the next one?
I mean, I can try.
Yeah.
So this is also, looks like the top was like epithelium. There was some epithelium on the top, and then this is like deep in the tissue. So it feels like the amount of parakeratosis on the top shows that it's probably like the acral surface, like somewhere maybe.
I think that's blood.
I'm trying. Oh, sorry. Okay.
There's only a little bit of keratin, yeah.
Okay. So, and then this is like, there's like hemorrhage on like low power. Three things I can appreciate. It's like, it's deep in the tissue. There's like fibrous tissue on top of it. And then there are like lobular kind of growth, but a lot of hemorrhage and pigmentation. So to start off with, I don't think that it's like something that is like very low grade, because I think it's growing fast. And I did see, like, when you were zooming in and out, there were like areas of necrosis. I do see some debris, and now the nuclear features or like the cellular feature. Okay, so there is irregular nuclear contour. The nuclei doesn't look, they're at peace with each other. They look angry, and they have like nucleoli. But the nuclear contour, and like almost all of the cells are like very, and then it's like they're forming kind of like, probably I'm not using the same correct term, but like glomeruloid kind of pattern, like when they're like, or cribriforming kind of pattern when they're sort of like that. But I'm thinking more about like malignant entity and cytoplasm. I missed cytoplasm. So it's not myxoidy. It still looks pinkish. So and it has like that because we are in the epithelioid version, so it does look epithelioid. So it does fit the. So I think it is where it is supposed to be. I do see some like cleared spaces. I don't know if they're making like lumina, or this is just like when the tissue is, I don't know. Do you know what I mean? Like this, like these
here where they're kind of almost like a gland or a duct or a lumen.
Yeah, exactly. But there's like pigment that is throwing me off towards something that is like, oh, is it like melanoma or something? But
so let's identify, is this a pigment you're talking about?
Yeah.
So what pigment?
Or is it hemosiderin?
Right. It's very globby and of varying size and brown, right? Melanin should be more fine and really dark, almost black, right? Very dark brown. So yes, this is hemosiderin, which still could help you, just in a different way.
Yeah. I mean, that makes me think that with a lot of that hemorrhage and then this hemosiderin and these dilated kind of vessels that are like leaky, or probably leaky vessels would be better. And then these like pseudolumina kind of thing, I would think about something that is malignant and that is like vascular in origin.
Right. So malignant and vascular means?
Epithelioid
angiosarcoma. All right. I think most people who voted got it. So the things to take in mind with this are, some people said epithelioid sarcoma, melanoma, completely reasonable because of a various number of things, including the large size of these cells with the prominent nucleoli, right? But this is a repeating theme in a lot of these epithelioid malignant mesenchymal neoplasms, is that they are large. they do have prominent nucleoli. They sometimes have rhabdoid. I was pointing out a couple cells with rhabdoid morphology. I don't know if you saw those, but all of these features are so overlapping. There's maybe one. So you have to see the subtleties around them, right? You have to see that these are forming almost ducts or vessels, right? So in this case, it would be vessels. And in some cases, you can even see that, oh, yes, the malignant cells that are forming these ducts or vessels have blood in them, so probably vessels. And there's a ton of hemosiderin. I know hemosiderin doesn't always help because you could have prior biopsy, etc., or just other type of hemorrhage, but hemosiderin and blood cells in an epithelioid soft tissue neoplasm should really make you think about angiosarc, okay? And so that's, in fact, what this is. So this is a deep, right? This is one of these deep soft tissue angiosarcs. This isn't a cutaneous sun-exposed angiosarc like we saw last time. That was very vasoformative, very clefting into the collagen. These epithelioid ones tend to just be, you know, more sheet-like, focally with vasoformation. We already went over this slide in the last one, so I'm not going to belabor it. But does any, I'm dysfunctional to see rhabdoid morphology. So we're going to see more things with rhabdoid morphology as we go along, but I think I'll continue to try to point it out. So who wants to do the next one? So this is another kind of fragmenty biopsy type of thing. Already there's lots of blood. For the sake of time, I'll start talking. What's the cell that you see a lot of in the background?
A lot of lymph.
Eosinophils.
A lot of EOs, right? Okay. What about these cells in between the EOs? Are they trying to form structures, or are they just sheet-like nondescript?
Forming small capillaries, maybe.
Yeah, I think they're like balling up on each other.
Yeah, they're kind of balling up, and they're trying to form either little balls or maybe swoops, right? Swoops of perhaps capillaries. Here's one, right, that has a blood cell in the lumen. The difference with this is, do we see very prominent nucleoli?
No.
No. Do we see necrosis?
No.
Do we see tons of mitoses? We may see a few, which is allowed.
We do not.
No. So, yeah, those of you who are voting, I wanted to show you the spectrum of epithelioid vascular lesions, ranging from benign to malignant to intermediate. And so this is probably one of the ones that is the most challenging. Now you've seen the malignant, you've seen the intermediate. Now, so many of you are getting the correct answer already. But when you see this in isolation, the plumpness of these cells can be worrisome, right? They're very plump, yet they are vasoformative. They are surrounded by these eosinophils, and they generally don't have other high grade features like tons of necrosis, tons of mitoses, you know, perineural vascular invasion, things like that. So those of you who voted for epithelioid hemangioma are correct. So epithelioid hemangioma is sometimes called angiolymphoid hyperplasia with eosinophilia, meaning basically this is a proliferation of very, very plump capillary-like vessels with a bunch of inflammatory cells in the background, usually EOs. Again, this is a soft tissue lesion, a bony lesion, and should be positive for your vascular markers. The thing that I wanted to point out in comparison between epithelioid hemangioma, hemangioendothelioma, and angiosarcoma is the fact that hemangioma and angiosarcoma are both vasoformative, being small capillaries in the hemangioma and various sized and shaped things in the angiosarcoma, right? But hemangioendothelioma, as I said before, is not vasoformative, except for the little intracytoplasmic blister cell luminas it's trying to form. All of them can be positive for your cytoplasmic markers of vascular differentiation 31 and 34, your nuclear markers of vascular differentiation FLI1 and ERG, and keratin or EMA. What else was I going to say? Comments? Questions?
So with these, sometimes I get these kind of confused with like the spindle cell hemangioma.
Okay.
There's been described the Kaposi form hemangioendothelioma. So
Yeah.
what is kind of, you know, when you get one of these, and you obviously don't want to call it angiosarc, but I mean, is it, you know, if you misdiagnose it or something like that as, you know, benign entities, spindle cell versus, you know, this entity, is it really a big difference? I mean, management wise, I don't think it's going to matter, right?
Right. If you're the most important thing is putting it in a benign hemangioma versus an indeterminate hemangioendothelioma.
Okay.
And so the hemangioendotheliomas, if you've read the book, which it sounds like you have, come in so many shapes and forms: retiform, Dodgka, spindle cell, Kaposiform, epithelioid, right? And so, and overlapping hybrid hemangioendotheliomas. So the most important thing is to really convince yourself whether you think this is a benign hemangioma or something in the intermediate or malignant. And it's not always easy, but for treatment purposes, that's most helpful, because these intermediate ones can metastasize. And so they'll probably, I'm not sure, depending on each clinical situation, if it's already multifocal, whether they would give treatment. But for hemangiomas, they're probably not going to do very much in terms of treatment, minimal observation. But the higher you get, the higher kind of acumen of clinical care these patients are going to get. So the categories are the most important. Probably the morphology is the least, because especially in the intermediate group, they can be very overlapping. But this is the one you're going to probably see most often. The others are quite more rare.
Okay.
Does that help?
Yeah. As far as like IHC for like lymphatic markers, I know we have D240. Do we have like VEGFR3 or the LIV1?
I don't use them, so I don't think we have them. If anybody knows differently, please speak up. The one thing you can do to differentiate benign from intermediate or malignant is actually identifying the parasites. So, so in epithelioid hemangioma, or things like pyogenic granuloma, lobular capillary hemangioma, they should still have a smooth muscle actin positive parasite layer surrounding these vessels, because they are still kind of recapitulating benign normal vascular morphology. In the angiosarcs, they will not have a parasite layer around them, neither really in the hemangioendotheliomas. So we have used the presence of a myoid parasitic layer around those to help put them in the appropriate category when it's confusing. Does that make sense?
Yeah, that helps.
Okay. All right. Anybody else have anything?
And
okay.
Can you necessarily use that for hemangioendotheliomas?
I've not used it for hemangioendotheliomas because I think the morphology in those is can be so distinct.
Yeah.
But we've actually used it to differentiate hemangioma from angiosarcoma.
Angiosarc, yeah.
Right, because sometimes people on the outside see, or people anywhere, even on the inside, could see plump, very plump, vasoformative things, and think about angiosarc. So actually, it helps differentiate benign from malignant more so than the intermediate, because the intermediate morphology tends to be quite different. So yeah, good point.
Just as a drop in here, Nicole, this is Aaron. Yeah. I've had several in the last few months that the outside says atypical vasoformative neoplasm. Mm-hmm. and that's an SMA or that demonstration's been part of our workup, and you know, they obviously not inevitably, but these just happen to be benign, all of them.
Yeah, totally. Good point. All right. Another fragmented biopsy.
I guess I can describe this one. So I'm not sure about location. There's a little bit of fat on the left side, but even at low power, we can see it's kind of these sheets of cells with kind of amphiphilic cytoplasm. There's a decent amount of pleomorphism. There's necrosis kind of in the left corner there. We also see some extravasated blood. Pretty prominent nucleoli in some of the cells. Architecture-wise, sorry.
Let me get to an area where the morphology is a little bit clearer.
Yeah, there's not a great pattern to them. I mean, so I guess at baseline, my differential would be pretty broad with the prominent nucleoli. I know we always think about melanoma. Based on location, could it be a met of like some sort of high-grade carcinoma? And then, of course, all the other things we have currently been discussing today.
All right, the thing that we certainly helps us out, at least for malignancy here, is the presence of necrosis and the very numerous mitoses. I think that we came across already a few. Yeah, here's a good one. Here's a good one. But right, morphology is, again, very plump with pink cytoplasm, prominent nucleoli. Let's see if we have. Yeah, so this is in, now you see the answer. So those of you who are voting, you keep going. But the thing that's going to differentiate this from the others is a couple of things: is location and specific genetics. So telling you that this is on the wrist or the distal extremities should kind of shift your thinking a little bit to certainly this is epithelioid and there's extravasated red cells. So of course you're going to want to think about angiosarc. That's absolutely correct in the differential. You're certainly going to want to think about a melanoma or a carcinoma. But again, just like the other epithelioid malignant neoplasms, this is going to be strongly keratin positive, okay? How are you going to not call it carcinoma? What immunostain are you going to do to not call it carcinoma?
NI1.
INI1. So what's INI1?
The SMARC A4 or SMARC
Like
something
B1.
B2, B1
Right.
family, which is lost in these.
What are those genes involved in?
The transcription factor.
Chromatin remodeling.
Chromatin remodeling. Okay, so I'm going to show you another example. So the epithelioid sarcoma, we have to think about as being on the distal extremities, so type 1, and on the proximal trunk. This is an example of it on the proximal trunk. So this was a chest wall mass. Okay, I'm just showing you this now to expedite things. This is a chest wall mass of, again, very ugly, mitotically active, prominent nucleoli. Here's like a giant cell that almost is turning into a rhabdoid giant cell with peripherally located nuclei and abundant cytoplasm. Let's see if I could see a few more. So pretty much any cell that has the nucleus pushed off to the periphery in favor of the cytoplasm to occupy the majority of its contents, you want to consider quote unquote rhabdoid. Here's maybe a vague one. But of course, you're going to think about rhabdomyosarcoma and any of your other epithelioid mesenchymal neoplasms, because a lot of these epithelioid mesenchymal neoplasms can have rhabdoid so-called morphology. And when you see that rhabdoid morphology, you want to not only think about rhabdo, not only think about your epithelioid mesenchymal neoplasms, but specifically to think about the chromatin remodeling complex deficient neoplasms, okay? That rhabdoid morphology is turning out to be quite related, all right, to chromatin remodeling complex problems. So when you're either in the distal extremities or proximal trunk and you have this morphology and you have keratin positivity, think about doing an INI1 and it will be lost in 100% of these, okay? So it's not like it is essentially diagnostic. The distal type tends to be a little bit more bland and kind of organized in these almost granulomatous structures. The proximal type tends to be somewhat more plump and, I don't know, juicy looking and just be organized in sheets, okay? So for both of these, of course, so strongly keratin positive that carcinoma is the first thing a lot of people think about. But please, 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 please don't forget, it's easy to just do the INI1. And I think this distal type epithelioid sarcoma is a little bit more obviously malignant than a lot of the distal types. Some of the distal types can be quite as bland as what I'm showing you here with this central collagenous sclerosis with these kind of almost histiocytoid cells at the periphery. All right, so does anybody have questions right now before I say another word on epithelioid sarcoma? What I want you to think about is the differential diagnosis of those granuloma-like lesions on the wrists and distal extremities. So it's very easy immunohistochemically to parse out epithelioid sarcoma from all of the other benign things. So your keratin and or EMA and your INI1 will define epithelioid sarcoma on the digits, hands, wrists, etc. All of your other bland histiocytoid things like rheumatoid nodule, granuloma annulare in the skin, you know, calcifying aponeurotic fibroma in kids. These are basically quote unquote fibrohistiocytic, right? So fibroblast, myofibroblast, SMA, histiocytes, CD68, CD163, not keratin, not EMA, not loss of INI1. All right, so at least just think about putting a keratin on these distal granuloma-like lesions. All right, if they're not as obvious as the one I just showed you. Okay, does that help? Does that make sense? The one thing I will put also in the differential diagnosis of epithelioid sarcoma is malignant extrarenal rhabdoid tumor, because of the very overlapping morphology and immunoprofile. So very plump, very rhabdoid, 100% loss of INI1, can have keratin, just like epithelioid sarcoma. The question that has arisen is, why is epithelioid sarcoma and malignant extrarenal rhabdoid tumor, are they actually different? When they look the same, they stain the same. Well, malignant extrarenal rhabdoid tumor tends to be in the sort of deep paraspinal region of young kids. Epithelioid sarcomas tends to be in the, you know, distal extremities or kind of peripheral, like trunk subcutis, not the deep paraspinal region. So maybe there's a locational difference, but really morphologically and immunohistochemically, they're essentially kind of the same. So I kind of put these together in my thought process of like, these are really, really similar, but have kind of different clinical contexts, if that helps. Okay, it's already 8:55, so let's move on. If anybody doesn't have questions, let's move on. I think the one thing that if I could impress upon you is it can be very difficult to, on H&E, just make 100% of a diagnosis without knowing the location, the age, and ultimately your immunoprofile, right? So these are tough. They all look very similar, but as long as you keep all of them on your differential, I think you'll be successful. And so this is a deep tumor that's also very necrotic, that's also somewhat hemorrhagic. I don't see necessarily extravasated red blood cells, but I do see maybe focal eccentrically placed nuclei with eosinophilic cytoplasm, eccentrically placed nucleus, eosinophilic cytoplasm, necrosis. I know you may have exhausted your options here, but does anybody want to think about what other lesions have we not really discussed yet? I'm giving you the answers. Right, so one of the lesions we haven't discussed yet is epithelioid malignant peripheral nerve sheath tumor. And so that's what this is. How do you know? How do you know? How would you know?
Stains?
Stains, what stains? What stains?
Oh, S100.
Okay, and?
SOX10.
And SOX10. How is it not melanoma?
Well, it doesn't have like the melanoma markers like melon A or HMB45 or.
Yep, that's pretty much it. Exactly. So epithelioid MPNST is basically a diagnosis of exclusion where the only thing that stains in it would be like an S100 and a SOX10. Just like the other epithelioid soft tissue sarcomas, right? It can be keratin positive, so that could help you. It should not have the melanocytic markers. It should not have the melanoma genetics. And sometimes it has loss of INI1, just like some of the other epithelioid malignant neoplasms, all right? So I just wanted to show you this to remember to put it on your differential, okay? Just remember to put epithelioid MPNST on your differential. Unlike the spindle cell MPNSTs, it, oh my God, Dr. Blair, it does, there's a frozen, it does stain for S100 and SOX10. Hold on one second. Hi, this is Nicole. Sorry, guys. Dr. Blair needs me to look at a frozen in a few minutes, but I think we're nearing the end, so let's just do the last case here. All right, so what's different about this epithelioid mesenchymal neoplasm that kind of distinguishes it morphologically from all the rest?
Is there some necrosis? Is this mucin between the cells?
Yeah. Or myxoid, I don't know.
Yeah, excuse me.
Like the cells are a lot smaller, they're less plump, what I can tell. Very eccentric nuclei versus the other ones that seem more central. Don't see prominent nucleoli.
So, right. So I think the main difference, you know, because you can still have eccentrically located nuclei. You can have lesser prominent nucleoli. Oh, here, look, here's even maybe a rhabdoid cell, right? Myxoid stroma, mucin, all right? So whenever you see myxoid stroma or mucin, you should think about what a few people voted for here, which is a myoepithelial neoplasm. Somebody, is Ben still here? Yes. I'm going to address your question, Ben, about melanoma losing those markers in 2 seconds. But what I want to show here is this prominent myxoid stroma. And so this is, again, where my head and neck and my bone and soft tissue overlap. So whenever you see this prominent myxoid stroma, think about a myoepithelial neoplasm. Remember that myoepithelial neoplasms can happen in the salivary gland, in the deep soft tissues, and in the bone. This particular one happens to be in the bone. All right, so these can happen anywhere. The things you need to prove are, one, first of all, are they benign or malignant? I think we can all kind of suggest that this is probably already malignant. There's lots of mitoses. I think there was necrosis. All right, but what's most important to say that it's a myoepithelial neoplasm to begin with is it has to have either keratin or EMA, so some kind of epithelial marker, and some kind of myoid or myoepithelial marker. So either muscly things like calponin or SMA, myoepithelial things like P40, P63, S100, GFAP. Just pick, you got to pick a keratin or an EMA and one of those bottom things, and you could put it in the myoepithelial neoplasm spectrum, okay? So it can have loss of INI1 in some cases. It can have EWSR rearrangement in about half. So these are also diagnostic kind of definitions that we can use to help us. If you are dealing with, I'll give you these slides so you can look at them on your own. But if you're dealing with something that you're uncertain about, sorry, I'm going to go back to Ben's question now. An S100, here's an S100 SOX10 positive tumor having lost the melanocytic markers, you kind of are almost implicated to do genetic testing, because if it's not obviously something else, right? If your S100 SOX10 positive tumor is not obviously anything else based on its association with a nerve, i.e. MPNST, its positivity for keratin is in a myoepithelial neoplasm. Its positivity for something like SMA as in a PCOMA, which I haven't shown you today, I apologize. You are almost required to do genetic testing to look for the c-KIT, the BRAF, or the NRAS mutations, which will then prove to you it's a melanoma that's lost its markers. Does that help? I know that this is, you know, this is practical, this is real life, right? Because sometimes you don't know. Sometimes you don't know. And unfortunately, genetics are going to be the thing that differentiates. So remember your melanoma mutations, remember in myoepithelial lesions, your EWSR, and sometimes your INI1 loss. We didn't talk about clear cell sarcoma, which is basically morphologically melanoma, but that exists in the deep soft tissue rather than on the skin, right? That's EWSR ATF1 rearranged. Are there any other questions? I know we kind of went a little bit quickly. I'll give you guys these tables, as well as my kind of summary on the chromatin remodeling complex markers. Remember that we're starting to find loss of the chromatin remodeling complex genes in a number of things, even some thoracic carcinomas. So what is it? Hypercalcemic carcinoma of ovary, right? Am I right on that one? Somebody who knows gynae, tell me.
Yeah.
So just keep the INI1 and the BRG1 in the back of your mind. If you do one, do both. If you have loss of any in the nuclei, you've kind of narrowed your differential at least to one of those tumors that has INI1 loss, or INI1 or BRG1. So SMARCB1 or SMARCA4. I hope this helps. I know the morphologies on a lot of these are very, very similar. So please look for the subtle differences. And please think about the immunoprofile that's going to help you decide, because more often than not, it will.
Thank you.
All right, thanks.
Thank you.
Sorry to frozen.